right. Good morning, everybody. We're going to go ahead and get started this morning. Is everybody rested today? Did you all go out and see the town of Richmond last night? Who did something fun? I know a couple of the ladies went to Carytown. Who else did something exciting this morning or yesterday? You guys didn't go nowhere? Yeah, you were studying all the information. You were studying that big textbook we gave you. So welcome back to our second day of our SCCAPE conference. Hopefully you all left here yesterday feeling that you learned just a little bit more about sickle cell than before you came in. We're going to be starting off today with some nutrition information, talking about mental health, transition, and then this afternoon really getting into the medical home and the roles, and the roles and responsibilities of community health workers. Our lovely, my lovely video crew would love to have a couple people do some individual interviews between breaks. And I would like to know, maybe without kind of putting anyone on the spot, would somebody volunteer? Would a couple people at least volunteer to do that when there's a break? Interviews? Okay. Nikki will. Thank you. So back in the back there's a little light, and when we have our next break, if you could just go back there, they'll make it very casual. They do a great job, and we really want to try to get some feedback from you of how you think things are going. So our first presentation this morning is from our outpatient nurse practitioner, Caitlin McManus, and she has been with us since February and had been a nurse for about 9 years prior to that. So please give Caitlin a round of applause.
All right, I'm gonna skip a couple of these slides. Can everyone hear me okay at this distance? Not enough, okay. Better now? Okay. All right. Thank you, Shirley, for the introduction. Again, my name is Caitlin McManus. I am the outpatient nurse practitioner for the sickle cell program here. I've been here since February, so still fairly new to the group, but it's been great learning from Dr. Smith and Dr. Lopato, being in the clinic setting. Prior to this, I was a nurse for actually about 5 years on the inpatient side. I worked on a medicine floor, so I did see sickle cell disease, but I really only saw sickle cell disease when patients were in crisis. So being on the outpatient side has given me a whole new perspective. Really seeing those patients who are managing their pain and managing their disease on their own on a daily basis. So that's been kind of something that's been really different for me and a whole new learning experience. And I'm still learning every day. Every day in clinic, my patients are teaching me things. Being at this conference, learning from you all has been awesome. So I welcome any feedback, welcome any tips that you have for me being in the outpatient setting. And we will get started. So I'm talking about living a healthy lifestyle this morning. And this is not something I really talked to my patients about when I was a nurse on the inpatient side. When people are inpatient, they're sick, they're acutely going through something, and talking about health prevention, talking about lifestyle is not really something they're interested in. Understandably, they want to get better and they want to go home. So these conversations have been something that I've started to have with my patients on the outpatient side, so that's what we're going to be talking about today. This is just an overview of kind of what we're going to go through this morning. I'm not going to focus too much on the complications of sickle cell disease, as Dr. Sisler did that yesterday, and then just maintaining a healthy lifestyle, and then health maintenance and prevention. So I bring this slide up, again, not to go through these all specifically, but I think the visual is really good to see, not only the visual of the human body, showing all of the different organ systems that sickle cell disease can affect, but just even looking at that list, that is a lot of different things that can be affected by sickle cell disease. And of course, all of us are very informed in sickle cell disease, and we've seen this in many of our patients. We've seen, maybe someone has just one of these things, maybe someone has 3 of these things. But many of our patients on the outpatient side aren't informed of all of these things, especially if they've had a pretty healthy life thus far, if they haven't had a lot of complications. I will have patients who, when I ask them if they've had a history of retinopathy, they say, "What's that?" Or, "I've never heard of avascular necrosis." So it's good to recognize that some patients growing up, depending where they grew up or who their provider was, or maybe just how informed they are, it's good to know that many patients don't know all of the complications that can occur from sickle cell disease. So that's why I just wanted to bring up this list, just to make sure that we know that not everybody knows as much as we do. So what else can our patients do? Besides taking hydroxyurea, besides managing their pain, on the outpatient side, I like to talk to my patients about things that any primary care provider would talk to their patients about. Living a healthy life, eating a healthy diet, getting regular exercise, not smoking. These are all things that maybe don't affect sickle cell specifically, but can lead to a healthier lifestyle and maybe indirectly can help our sickle cell patients. And it's really part of my job as their outpatient provider to make sure that they're still aware of all these things, especially as many of our patients don't have a primary care provider. They're only seeing us. So really, maybe I or maybe Dr. Smith, Dr. Lopato, maybe we're the only ones talking to them about this kind of stuff. So diet is something that is kind of tricky. I have many patients who come in and ask me, what can I eat to make my hemoglobin go up? What can I eat to help me avoid going into sickle cell crisis? And it's great when people ask these questions because it makes me know that they're interested in doing other things non-pharmacologically for their sickle cell disease. Unfortunately, a lot of times I don't have a great answer for them. There's not a lot of foods that we know that can boost your hemoglobin. I do have a lot of patients, well, I guess a few patients who have come to me and said, my sickle cell is doing way better, and I'll ask them what they've been doing differently, or if it's something we've been doing differently. And they'll say, I'm going to the gym, and I'm eating better. I'm eating more fruits and vegetables, proteins, not as much sugar or carbs. This is something that obviously is dependent on the person. And obviously things that I try to pass on to other patients, but this is a mindset. It's hard to make lifestyle changes. So I certainly welcome any thoughts that my patients have. They'll come to me asking, hey, can I try this new diet? What do you think? And certainly I say, go for it. More power to you if you would like to try it. If it helps, then great. So really just encouraging them to try different things and see if it's helpful is something that I like to do. I also wanted to mention vitamin D. We talked about vitamin D a little bit yesterday when we were talking about bone health, calcium absorption. This is something we regularly check in sickle cell disease because it does tend to be low, and we do supplementation if necessary. But also I had read a couple articles recently showing that lower vitamin D levels are associated or maybe correlated with more crises-related hospitalizations. So I thought that was really interesting. And another article showing that vitamin D may have some anti-inflammatory effects. And we know that inflammation is a big part of sickle cell disease, especially in the vasculature. Knowing not only that the red blood cells are affected, but even the vessels in your body can be affected. So, this is just a theory. Maybe vitamin D is playing more of a role than we know. So I just thought that was really interesting and wanted to make note of that. Physical activity. This is something that's highly individualized for our patient population. You know, everyone who goes to their primary care doctor, any of us, if we go, their primary care can say, okay, you need to get 30 minutes of strenuous exercise 3 to 5 times a week. You know, and quite frankly, we can't tell our patients to do that. That could lead to a crisis. That could lead to increased stress on the body. That being said, it is still important to get some physical activity. This can help mentally, kind of take your mind off what else is going on in your life. So I do like to talk to patients on an individual basis about what they can do. Obviously, we have a very wide range in sickle cell disease. I have one patient who is still able to run for 20 or 30 minutes at a time without going into crisis. And then, of course, we have some patients who have pulmonary hypertension, who have heart failure, and can't, you know, walk from one end to the other of this room without getting short of breath. So that's why it's good to just have these conversations with your patients about this. The other thing is working with your patient to kind of know what their limitations are. My patient who runs for 30 minutes at a time, I actually saw him last week in clinic for a same-day visit because he was having increased pain. And when I saw him in clinic and talked to him about it, he said, yeah, I normally, you know, I go for my 20 or 30-minute run and I start having this pain and I know that's when I need to stop. But today I wanted to push myself and it was a bad idea. So patients know their bodies, they know their limitations, and they just have to know and make sure they know that they should listen to their body. They can't push themselves like everybody else. If they go to the gym with a friend or if they go to an exercise class, obviously people try to be encouraging, that's what people do at the gym, but maybe they're not able to keep up with their friends as much. They need to drink double the amount of water. But knowing your limitations, knowing when to stop, that's the most important thing. At the same time, I have another patient who was excited about going to the gym with his brothers. His brothers go to the gym for like 2 hours a day or something crazy. And so I encouraged him to go to the gym. We followed up. I said, what'd you do at the gym? Like, what did you do with your brothers? He said, well, I went to the gym, but I just sat there because I was afraid to do anything. I don't want my patients being afraid to, you know, push themselves a little bit or at least get themselves out there just because of their sickle cell disease. I don't want them to feel limited and feel like they can't do anything because of their sickle cell disease. So generally, I'll tell people, if you're interested in starting like a physical activity routine, just start with 10 minutes. That's all you have to do, 10 minutes per day. Go walk around the block, go walk on the treadmill. Generally, we like to do more aerobic activity, like walking or maybe jogging if that's possible, as opposed to like lifting weights, which builds up lactic acid and can be a little bit not as beneficial, I guess, or lead to more crises. So yeah, so it's something that I think is worth having a conversation with your patients about and encouraging, but also teaching them to know when to stop. Hydration. All of our patients know to hydrate. They probably hear this word, you know, just as much as pain or just as much as hydroxyurea. They know that they need to hydrate. I try to ask my patients, exactly how much are you drinking in a day? You know, a lot of patients will bring in a soda bottle or a juice bottle and they'll say, oh, I drink, you know, a couple of these. Really, you should be drinking, you know, if you have a juice bottle that's, you know, 16 ounces, you should be drinking at least 6 of those per day. And half of those should be water. It shouldn't just be juice. It shouldn't just be soda, coffee, tea. A lot of those things can dehydrate you also. So I like to actually put a number on it so they have a visual of how much they should be drinking. Stop smoking. This is very easy to say. We all know that we should stop smoking if that's something that we partake in. Obviously, having the conversation is always good. Maybe it goes in one ear and out the other. But I like to emphasize it, especially with our sickle cell population, because of the effects that smoking has on the vasculature. And now that we know that sickle cell disease is not just a red blood cell disorder, it also affects the vasculature. Why would we do something else that also, constricts the blood vessels and makes it even harder for our red blood cells to get through? So I like to kind of put that visual in people's minds, because when people think about smoking, they just think about their lungs, they think about their breathing. So kind of putting that visual on it, I think, is helpful too. Obviously, we have lots of different things we can do, Chantix, we can do nicotine patches to help. People don't have to quit cold turkey. It can be a stepwise approach. I had someone actually bring up the stepwise approach for the nicotine patches the other day in clinic. Or even just cutting back. I have a patient who smokes a pack a day. At our last visit, I said, okay, next month, just try and cut that 20 cigarettes a day to 17 cigarettes a day. Even just cutting back by that much, and let's see if you can do that. And even just setting small goals like that for each month is more helpful than just, quit or don't quit, and, then they feel like they failed because they haven't quit. So just doing that little bit by little bit makes it a little bit more reachable. Health maintenance. This is just a list of things I like to talk to my patients about in clinic in terms of getting other routine visits in, immunizations, things like that. Dental care. I guess this came up yesterday. I don't think I was here for it, but I know it came up just in terms of insurance. So this can be a barrier for our patients. We do still recommend that people get checked out every 6 months. That's the general recommendation for everybody. And kind of apart from just looking for cavities and getting routine cleanings, it's also important to assess for infection, for dental abscesses. Getting routine cleanings can help avoid these dental abscesses. And our patients are at risk for infection. Infection can lead to crisis. So this can be something that's really major. We have had patients who come to clinic with abscesses already forming, and we can give antibiotics and try and get them in with someone to get that taken care of. But I understand it is definitely a barrier because of insurance. Sometimes you can find, at least here at VCU, sometimes we're able to refer to the dental school because we'll see patients for free because it's the dental school, not like a dental clinic. So that's really helpful. Obviously, that's not available everywhere, and I don't know the limitations on that, but it at least is something. Routine eye exams. So we talked about retinopathy yesterday too. Obviously, this is most important with genotype SC. But it is, a lot of times when I bring up going to the eye doctor, I hear, oh, I don't need to go to the eye doctor because I don't need glasses, my vision's fine. A lot of people haven't heard of retinopathy. They don't realize that sickle cell disease can affect your eyes. And this is something that can happen over time, slowly. It's not something maybe that happens all of a sudden right away. So it's good to go to the eye doctor every year. I make sure to tell them to make sure the eye doctor knows they have sickle cell disease, so they do that dilated eye exam. A lot of people will come in and say, oh yeah, well I got my new glasses, but I make sure to ask them specifically, did you get your dilated eye exam, just to make sure that they know, kind of what we're screening for and what that risk is. I don't know if I know the difference. I always tell people to go to an ophthalmologist just because they know a little bit more about sickle cell disease. I think optometry, they just do the visual. Yeah, they just do the visual, like eyeglasses and contacts and stuff. Ophthalmologists, we always refer to ophthalmologists because they know to do that dilated eye exam. They know what to look for in terms of retinopathy. Immunizations. This is pretty standard. We should get our flu vaccines, we should get our pneumonia vaccines, not only to prevent these diseases or decrease the severity if you happen to get pneumonia or the flu. But really, at the end of the day, we're trying to prevent these so that we prevent a sickle cell crisis or we prevent acute chest. So kind of when I put it in that perspective for patients, it hits home a little harder. Not just, well, I get sick if I get the flu shot. I say, would you rather have a little bit of sickness or would you rather be in the hospital with the flu and be at risk for acute chest? And many of our patients have experienced that before, so that hits home a little harder. Other healthcare providers. So obviously if patients have other medical conditions, other chronic conditions related to sickle cell disease, we have people who see the pulmonologist for their pulmonary hypertension. We have patients who see the nephrologist if they have kidney damage. I still like to emphasize that people should have a primary care provider. We focus on sickle cell disease, and that is fine for most of people growing up and kind of tackling those day-to-day complications. We can treat a UTI, we can treat your hypertension and give you something to lower your blood pressure. But as people get older, there are routine screenings that primary care providers will do that we just, we're not really even thinking in that kind of track when we're in the sickle cell clinic because we have a specific focus. We don't do screenings for cholesterol or diabetes we can, but it's just not really what we're thinking about. So I do like to tell people that, especially as they age, hey, you should probably get a primary care provider so that you can get these routine screenings too. Just because we have sickle cell disease doesn't mean that we're not at risk for other things also. And then just routine screening, your routine EKG or, just other tests that they do and kind of have a better idea of. And it's good for our young people to kind of get in with a primary care provider kind of at the start, because then your primary care provider will know you. You can establish that rapport. So then when something, God forbid, does go wrong, they already know you and kind of know you with your sickle cell disease and anything else that's going on. And this also goes for women with OBGYNs. We can talk to our patients about pregnancy, the risks for pregnancy, and how that is affected by sickle cell disease. But they still should be seeing an OBGYN for routine pap smears, for birth control, especially if on hydroxyurea. And obviously, if someone does get pregnant, they should be seeing an OB regularly for that care. Social support. This is something I like to talk to my patients about. Doing things out, obviously our visits sometimes are very medically focused. Having support we know affects our patients and their sickle cell disease. Having someone that can help them in times of crisis, having someone who can help them day to day deal with their chronic pain, or even just having something to distract them from all of these things. Going to church, going to a volunteer group, going to a support group. I know we have some support groups around Richmond that my patients have told me about. Even just being able to talk to other patients with sickle cell disease is helpful for people and coping strategies and things like that. I rely on my patient navigators actually to have these conversations also, because a lot of times, they know the patient navigators better, and they kind of have established more of a relationship sometimes, especially because, I'm only 7 months in to this job and people are still getting to know me. So a lot of times it's better maybe not coming from me, maybe coming from someone else, but it still is very important. Do you have a question? Mm-hmm. Yes. Right. Right here. Yes, that's a great point. Yeah, and we have some in Richmond too that we're involved with. So thank you for bringing that up. All right. For our patients who do have jobs, This is something that is difficult for a lot of patients to hold down depending on their, how many times they go into crisis, what their daily pain is like. And I really applaud any of my patients who are able to have a job and work with their sickle cell disease. If they do have a job, whether it be part-time, full-time, depending on what the job is, I do like to give some recommendations, not only to the patient, but if the employer would like a letter just to kind of help the employer understand sickle cell disease, I'm always happy to do that. If patients are sitting at a day job for most of the day, emphasizing that they need to get up every hour or hour and a half to walk around, just take a quick walk, hydrate, go to the bathroom to prevent blood clots. That's really important. If they're standing on their feet all day, if they have any lower extremity swelling, that can put you at risk for ulcers. So making sure they sit down every once in a while, put their feet up. These are all really important things to remember when you're at work. And sometimes it is hard for patients to advocate for themselves and say, hey, go to their boss and say, hey, I need to take more breaks, or, I need to, not stand on my feet all day. That can be difficult for patients to do. So anything I can do as their healthcare provider to help communicate that to their employer is, I like to help in any way. And this is also just a good opportunity for patients to have that conversation with their employer. Maybe their employer doesn't know anything about sickle cell disease. We talked a little bit about that yesterday with education. Using this as an opportunity to teach other people about what your needs are with sickle cell disease and what is beneficial. It's great to kind of spread the word. Another thing I'd just like to bring up, if is extreme temperatures with the work environment. We had one patient who was working in the freezer section, and obviously that was not beneficial for his sickle cell disease. He ended up getting another job, thankfully. We had one patient who worked somewhere, and she had to stand outside for a vast majority of the day. So we had to write a letter and have some conversation about that, because over the summer, when it's 95 degrees in Richmond, we can't have our patients standing outside all day on their feet, getting dehydrated. So it's just a matter of having that conversation. Obviously, it's just something that is employer dependent and job dependent and really patient dependent. So just good to have that conversation and make sure that your patient knows that you are willing to help them through this. So yeah. And of course, fluid intake, going to the restroom, and we kind of talked about these. So I think we have one of these questions now. I need to remember how to do it. Okay.
You got it.
I think this is it.
You got it. Very good.
Okay. So the question is, what would be the best exercise for patients with sickle cell disease? Am I supposed to click something? Oh. Okay. I'm seeing a lot of really good answers here. So these are all really good. Walking, aerobic activity, yoga, anything that's light cardio, stretching. CrossFit might be difficult. stationary bike. I do have a patient who actually attends those cycling classes, which I thought was really impressive. Do I keep this going, or what do I do here? Any comments or? Oh, okay. Still going. Okay. All right. Yeah. Okay. All right, so we have a lot of really good answers here. I see a lot of walking, yoga, swimming, aerobic activity. I had a question about aerobic versus anaerobic activity, and kind of what is better, weightlifting versus walking or running. When you're weightlifting and really just putting the strain on those muscles, but not, I guess, when you're walking, you're pumping your heart, you're moving that blood flow, and that helps oxygenate your muscles, and doing those 10-minute segments is good because it still allows your body to rest and continue to vascularize and get that blood flow to your muscles. When you're lifting weights, you're just putting stress on your muscles. You're not working that blood flow as much as if you were doing aerobic activity like walking or swimming. And that can cause that buildup of lactic acid, which, and we all know, we've experienced lactic acid buildup when you get that burning sensation in your legs or hiking or lifting weights. But having that kind of increased pain can lead to crisis, having that lactic acid buildup. So does that kind of explain it a little more? Lactic acid buildup. Lactic acid is something that your cells produce when they're not getting oxygen. It's kind of a byproduct of deoxygenation. And so like if you're working out and you're feeling that burning sensation, that's the buildup of lactic acid. So that's kind of a good signal. Okay, I need to rest, give my muscles some time to get that oxygen to them. And that's kind of what exacerbates that pain crisis, is that lack of oxygen. Yes.
I think that karate and jiu-jitsu, those are all great things, but
yeah,
just thinking about the trauma part of it,
mm-hmm.
And get hit in a certain spot and causing a pain crisis, just keep that in mind.
Can I actually have you repeat that in the mic just for the video?
Sure. I was just saying that I think that jiu-jitsu and karate are very great activities. However, just keeping the trauma aspect in mind, if you get hit in like a certain area and it triggers a crisis, that could not be the best thing.
That's a great point. And we can actually pass the mic if we have questions or comments.
So just with the weightlifting, it's similar with like aerobic activity. You can do light weightlifting,
right,
where you're not putting that strain on your muscles, so you're not lifting to build bulk,
right,
but you might be doing weights so that you can get definition and tone. In that case, it's lighter weight, so you're not really getting that lactic acid buildup. So it's still something that can be done.
Yeah, everything in moderation.
I just wanted to make the point that we as providers are really horrible at telling our patients how much or when or how to exercise. because there's not a lot of information about what's safe and what's not safe and how hard patients should push. And we did a survey, and what we found is most providers say, exercise until you feel tired. Well, if you exercise until you feel tired, that's like, for me, that's pretty early on. Like if I stop, if I stop when I get tired, I'm not going to get a lot of benefit. So there's some really good work going on right now trying to understand, how hard patients should push to get the benefit without putting them at risk for having complications or pain. But I think that's why it's so important for you guys to have this conversation with patients, because I know that we do a predictably horrible job of talking to patients about it.
What type of research has been conducted looking at the effects of exercise on sickle cell disease outcomes, and what has that research shown?
Yeah, that'd be great.
So we actually did a study here looking at exercise and sickle cell disease, and we worked with the exercise physiology folks on the undergraduate campus, and we had young adult patients. They were on a stationary bike, they were hooked up with the oxygen mask, and we were looking at their kind of exhaled gas and looking at how hard they were working. And we had patients respond with, how fatigued do you feel right now? How hard do you feel like you're working? When do you think you should stop? And what we found is that patients stopped well before they reached that safe kind of cutoff where they were no longer safe to exercise. So compared to the general population, sickle cell patients in our pilot study were not very good at knowing how hard to push themselves. What that sets us up for is what we hope will be the next step, where we can actually work with a trainer to teach people those physiologic cues, like how far really can you push yourself. But the answer is there's not a lot to say what's safe and what's not safe, and it's so different from patient to patient. But what we did find was in our study, even when patients pushed themselves past that point of kind of getting into anaerobic, most patients didn't have any pain or any complications afterwards. So patients most of the time know their cues, and if they can kind of stick to that, but there's a lot of work that still needs to be done.
I'm just curious, you said that they stopped well before that point. Did they say why? Was it the fact that they stopped because they didn't want to get to that point, or they just stopped because they thought they were at that point?
They thought they were at that point. So the physiologic cues, I think that the process of kind of, if you have chronic pain, we know that the pathways about how your body interprets pain change over time. And so I think, I don't know this with 100% certainty, but I think that patients just kind of their wiring is different because they've experienced chronic pain. And so they feel like they're at that point where it's not safe to go on well before they are. Most patients didn't express a worry that they would, and even our patients who were in the study who exercise really regularly, they still were not great at knowing their physiologic cues.
Can you share like what's going on in the body when they go swimming and they go for that hot, cold temperature, or even just like when the regular weather, standing outside in cold? What's going on specifically in the body?
Well, I think that most of the time with swimming, it's temperature and not necessarily the exercise itself, and kind of that being in the colder water, or then that feeling when you get out of the water and you're freezing because you were fine as long as you were in the water, but then you get out, and the temperature change over time changes your red cells' tendency to sickle. So if you have those extreme temperatures, you can actually shift your red cells' tendency towards sickling. So I think the swimming is more of a temperature thing. Do you all know any different? Yeah. Mm-hmm. A lot of patients tell us that. And we even had patients who do, some patients are fine if they're in a heated pool, but they know that they can't do like the ocean or anything that's not heated. But some patients even in heated pools really describe having a really difficult time.
All right. Sorry to cut you off. I think we are just about finished time-wise. Uh-huh.
In regards to persons that have trait, in the military and athletes, when they're being trained for their sport or for PT with that military, a lot of them are unable to go through those exercises. I don't know if it's too strenuous or what, but what happens and why does that occur when, I mean, they will die, some of them.
With the sickle cell trait, you mean?
Yes.
I don't know the answer to that question. Okay, yeah, we can re-ask that question.
Okay.
That'd be great. All right, well, I'm going to hand it over to Shirley. Thank you all for listening.
Are we moving? Uh-oh. Are we frozen? Caitlin, were you just moving it with the arrows? Reserve.
Oh, yeah. Where was that? But we just have to pull this back up.
Oh, that's
And
right.
then,
Go back down. There we go.
Yeah.
Oh, we don't have a screen this morning. Okay, it's time for our giveaway. Hopefully this works. Our digital person had to go to class, so. There we go. It's not up there, though. Okay, I have it in front of me. I don't know why it's not up there. Do you have any clue, Thomas? Okay. So you'll have to just trust me, and then when Daniel comes back, hopefully he can help us out. So those of you who won yesterday, your names will not be on the wheel today. Oh, so this is Dr. Cheedy, and I know he's not here, so.
Yeah.
Can you do it?
Oh.
I got it pulled up.
Maybe we have to escape that. Maybe we have to actually do that.
There we go. I am not technology savvy. I'll be the first person to tell you that. Tamika Ashford? Yay! Oh, you won? Oh, okay. I don't know what's going on with this thing. Well, thank you for being honest. I try to take you off again. I don't know. I keep hitting the remove button. I don't think she's here. Okay. We'll try this again. So far, we're not having anybody. Charles? I don't think he's here either. Okay. So we're not giving anything away. Marsha Newsom? Now you guys, I am removing the names and they are not going away. So I don't know what the deal is. I know. Edith? Ah! Woo-hoo! We got one. Oh, we're so excited. Thank you. Okay, we'll see if we can give a couple more away, and then we'll get started. Latrice? All right, one more, and then we're going to move on. She won yesterday too, right? All right. Well, that was very stressful. Speaking of stress, first of all, did everybody get scanned before the next session begins?
No, I think they need to start scanning.
We did not scan anybody? Okay, my staff, you got your table assignments. We got you scanned before the last session, but now there's no breaks in between these sessions, so they got to come around and scan you. So while they're scanning you, I guess we gotta wait.
I'm dancing.
Oh.